This training has to do with your lives, with things that can be done by you to prolong your lifespan and to counteract the impact of those medications. Just by being seriously mentally ill, you run the risk of developing or contracting serious illnesses that will compromise your mortality. Persons with serious mental illnesses have a life expectancy 25 years shorter than the average American. That's a lot of years to lose. I heard in the early 90s that people with serious mental illness lived on average 10 years less than everybody else. That was accounted for largely by people's lifestyle, substance abuse, etc., etc., etc. Those factors in many instances, actually in most instances, are still there. The one difference has been the advent of the atypical neuroleptic medications like Zyprexa, Clozaril, Abilify, Seroquel, Geodon, etc., etc. These medications, particularly Zyprexa and Clozaril, are known to impact an individual's neurotransmitters in two important ways. One, they increase appetite, and two, they impede the absorption of insulin. If your insulin isn't working, all that stuff that you eat just accumulates in your body as fats and as sugars, particularly as sugars, and can lead to increased blood sugar and can lead to diabetes too, or diabetes mellitus. And anybody who suffers from diabetes is a sure candidate to develop cardiac disease. And there's only two things that impact favorably on lessening the development of cardiovascular illness: diet and exercise. That's it. I wish there was an alternative to taking these medications, but many of you have learned already that if you stop taking these medications, you might spend a hell of a lot of time with psychotic symptoms and a hell of a lot of time in psychiatric hospitals. So right now, folks with serious mental illnesses are faced with a very, very, very difficult choice: to take medications that can keep your psychiatric or psychotic symptoms in check, and on the one hand and on the other, to take medications that will, unless they're carefully monitored and coupled with attention to diet and exercise, can dramatically shorten your lives. It's really crucial that folks providing the medical care communicate with folks providing the psychiatric care. If you're working with a psychiatrist who's prescribing Zyprexa, well, he should also order blood tests to determine what effect that Zyprexa is having on your cholesterol, your LDL, your HDL, your triglycerides, and your blood sugar. And whatever those results are need to be communicated to your primary care physician so he can make necessary changes. Metabolic syndrome. There's a monitoring protocol that was developed in 2004, 6 years ago. The key factors of the metabolic syndrome: obesity, dramatic weight gain; insulin resistance, that is elevated glucose or blood sugar; diabetes; dyslipidemia, which is elevated cholesterol; and hypertension. That's the metabolic syndrome. Every one of these things is measurable. Every one of these things can be monitored. Every one of these things can be addressed, although sometimes with difficulty. When it comes to obesity, if in the United States a man has a waistline greater than 40 inches, he's considered obese. If a woman has a waistline greater than 35 inches, it's considered obese. So every time you go see your psychiatrist and you're taking atypical medications, he should whip out the old tape measure and measure your waist. At the very least, should keep a record of your weight if you're gaining weight. Triglycerides. Ideal triglycerides should be less than 150 milligrams. Your HDL cholesterol, the good cholesterol, with men, it should be greater than 40 milligrams. Women should be greater than 50 milligrams. Blood pressure should be less than 130/85. And fasting blood glucose should be less than 110. If they take your blood glucose, say several months in a row, and it's always over 120, it's creeping up there, that means you're in the early stages of or at risk for developing diabetes. Anything over 150 consistently, you got diabetes. The way this monitoring protocol starts, and when you first see your primary care physician or even your psychiatrist, they got to do a personal and family history at the start and annually. Okay? So they should know if there's a history of diabetes in your family. They should know if there's a history of heart disease, because if you got a history, you're more likely to develop it. They should take your weight at least monthly, waist size regularly, blood pressure regularly, fasting glucose regularly, and fasting lipids regularly, so they can monitor what's going on with you. And then if it turns out that these values begin to go up, their options are to try another medication. If you're on Zyprexa, are any of you on Zyprexa right now? All right. There might be these other problems as well. You need a blood test immediately. You need to also take the results of that blood test and discuss them with your physician to make sure that these values aren't going up. If they are, tell them you want to go on another medication.
I'm afraid to stop it because I feel I'll get very sick and they'll put me in the hospital.
You have to talk to a psychiatrist. And again, if you have a good relationship with your psychiatrist, he'll listen to you. If you have a psychiatrist who you're concerned might not take your complaint seriously, you have to line up support, you have to rehearse, and then you need to go and talk to him. But that's a reasonable request to ask for blood tests.
And I take it I should be firm. If he says, oh, you don't need it, I say, well, it's been a year or 2 years or 3 years, let's get a blood test.
Exactly. Do any of you ever go to see your primary care physician with a friend? Or do you always go alone? Because it would be a very good practice if you have a friend that you can trust to bring a friend along. And rehearse with that friend ahead of time what questions you want to ask your primary care physician. With that person there for emotional support and for practical support.
What if your doctor says to you, I know best, and sort of shortchanges you? How do you go about putting your case forward? Even though you might be unaccustomed to speaking up for yourself, it's a behavior you need to acquire. And if these things aren't happening, ask why not. Ask. If I'm your psychiatrist and you ask me these questions, what am I going to do to you? So if I get pissed off and say, oh, why are you asking me this? You tell them, because I'm afraid I'm going to die. Or I'm afraid I'm going to get sick.
Residents have the cards stacked against them when the psychiatrist doesn't listen to the patient. The home automatically says you must do what the psychiatrist says, and you know that these drugs are hurting your body, and you are powerless to help yourself.
You're never powerless. You might feel powerless, and you might have been made to feel powerless for an extended period of time. But as soon as you stand up on your hind legs, particularly if you're supported by other persons. I mean, if you're alone and you're saying this, then you can be marginalized and depicted as a crazy person. But if you have a number of people who are there to support you, then it's hard for the psychiatrist to contest that, particularly if you make your statement in a reasoned, reflective way. If you get pissed off at the psychiatrist and say it in an angry, out-of-control way, well, then you can be labeled as a nut job. And then you can invalidate yourself. So if you're going to do this has to be rehearsed. And you have to make sure that you have support. Whenever you begin to act as if you have some power after you've been accustomed to behaving like you're powerless, it's always very frightening. It's a huge step. I don't think anybody in this room is powerless. I don't think anybody in the home, any of your fellow residents are powerless. But it appears that a lot of people feel that way. So a new behavior has to be learned. Namely, how do you stand up on your hind legs and ask questions and get answers?